الجزء اللي بالانجلش. بسم الله الرحمن الرحيم. Welcome everybody, and thank you for joining us in this course. Thanks Prof. Mervat for this great opportunity to be with you again in this new release of the course. Hopefully this will be beneficial. Today we will review in a short duration the basic EB study. We will use simple terms. Hopefully, things will be clear. When we start EB study, we start explaining that it's almost exactly like we are doing an electrocardiogram, but from inside the heart. It's very similar to many of you to the use of temporary pacemaker wire. If I have a patient with complete heart block or a patient doing coronary intervention with bradycardia, I insert temporary pacemaker. This temporary pacemaker is inserted in the right ventricle and connected to a battery outside or a device outside to control the output and control the heart rate. So we have EP catheters which look almost the same like temporary pacing catheters. They are lumenless catheters. They have electrodes at their tip, and many of them has fixed curves. Some have curves that I control from outside the catheter, and some have more than one curve. I implant these catheters in strategic locations in the heart to allow monitoring of the four chambers of the heart. One goes in the right ventricular apex, one goes in the right atrium, and one goes in the His region. What's meant by His region is the junction between the right atrium and the right ventricle. And this regions, it record the activity from both the atrium and the ventricle and from the His bundle at the end of the AV node. Then the four catheters go inside the coronary sinus, now monitoring the left atrium and left ventricle, and thus I'm monitoring the four cardiac chambers. I follow the sites via fluoroscopy. I use different views, AB view, LEO and REO view. And now I go to the recording system. The recording system gives me the intracardiac ECG as we described. We put the surface ECG to guide us, and then we have the different catheters. Every catheters give maybe 1, 2, or more than 2 recording according to the number of electrodes in each catheter. Each catheter is given a color. This color may differ from lab to lab, but in your lab, you'll have the same color every time. So you know where the catheter is located from its color. And each catheter shows the electrical activity from the site at which it's implanted. So if it's in the ventricle, it will record the ventricular activity. If it's in the atrium, it will record the atrial activity. And if it's in the His region, it will record atrial activity, followed by spike denoting that the impulse has reached the His bundle, and then the ventricular activity. To know what is recorded in the catheter, I go with the QRS complex. Anything that's simultaneous or almost simultaneous with the QRS complex referring to a ventricular action potential or what's look like QRS complex, and all potentials away from the QRS complex referring to atrial activity. When I do a study, all I do is I am studying the conduction that's occurring in the heart during rest, at normal rest, and with basing. Why I do basing? I do basing from different locations. I do basing from the ventricle, I do basing from the atrium, and the target of my basing is to detect the pathway of conduction. The pathway of conduction, is it the normal pathway, the normal conduction system, or do I have an extra pathway of conduction? This extra pathway of conduction may be the substrate of the tachycardia. Either it's an accessory pathway or an AV nodal accessory pathway, the cause of AVNRT, or something like this. So I am basing to detect abnormal conduction pathways that may be the substrates of the tachycardia. What follows is an example of our basic study or diagnostic study in cases of supraventricular tachycardia. Most commonly, we do supraventricular cases. So you have a patient with documented supraventricular tachycardia, and this patient have it mostly paroxysmally, comes and goes. It responds to either drugs or DC shock, and it's repeated maybe for a long time or long history for the patient. And now I go with this patient to the lab to do a study and to detect the type of tachycardia and then determine the ablation target that I am targeting. First, when I am doing a study for supraventricular tachycardia, I start with ventricular pacing. Why I do ventricular pacing? Because ventricular pacing will give me many informations, many useful information and necessary info. And again, I delay atrial stimulation because atrial stimulation may induce atrial fibrillation, and this atrial fibrillation may make the study harder and even impossible. So I delay the atrial stimulation to the last till I get almost all the diagnostic data I need. So if I needed to terminate atrial fibrillation, I can go and manage the tachycardia. First, we start by basing from the ventricle. What's meant by basing from the ventricle? I am basing from the catheter implanted in this region, in the RV apex. And the impulse is going this way in the conduction system, or if there is any other conducting pathway, it will go through it also, and may conduct back to the atria. And I am using this to detect first if there is a VA conduction or not. VA conduction means conduction from the ventricle to the atria. If there is VA conduction or not. If there is no VA conduction, many types of tachycardia can be excluded, like AVRT, and AVNRT becomes highly unlikely. And maybe atrial tachycardia is the most common cause in this scenario. And if there is VA conduction, I see where is the A is conducted. Is it in the catheter located here in the His catheter? So this means that the conduction occurred mainly via the normal conduction system, or is the catheter located here, the distal coronary sinus, which means that the conduction occurred via an accessory pathway, maybe left-sided accessory pathway or something. So I start by basing the ventricle, and I see this pattern. This pattern is this sharp spike. This is seen on all electrodes, on all catheters, and this shows us the spike or the QRS or the spike that coming from the basing, and from the channel which is responsible for the basing, or where I am basing from, I see this rectangular pattern. This rectangular pattern is refers to the origin of the spike, but all the rest of the caster shows this line. Then, if I see the surface ECG, I see clearly this is a based complex. It's like basing from a temporary pacemaker or even a permanent pacemaker. It's negative V1 because I'm basing from the right ventricle. And now I am basing. So I am basing from the RV apex. I am capturing because I'm causing QRS complexes. And then I look to see if my basing is causing a retrograde A wave. There is an A signal following every V. And here I see there is an A following every V. I have different types of pacing. I have straight pacing. What's meant by straight pacing is that I'm pacing at a fixed rate, like 600 millisecond interval, or more or less, but it's fixed, and maybe I increase it during pacing. And I have what's called an extra stimulus testing. What's meant by extra stimulus testing is that I have a train of 8 beats, usually 8 beats, with fixed distance, like here it's 600 millisecond between S1 and S1. And at the end of the train, the ninth stimulus is coming shorter duration. Here it's a 400. I call this S2. And I'm repeating it. Next train is 600, 390, 600, 380. And it goes like this. I am assessing with ventricular basing that I am basing the ventricle, I am capturing the ventricle, I am causing retrograde conduction or not, and where is the conduction occurred first in the atrial catheters, and here I see it's in the His region. And another thing is that with conduction via the normal conduction system and the AV node, I find what's called decremental conduction. What's meant by decremental conduction is that with increased rate of pacing or with shorter S2 interval, I have a longer time of conduction. Longer time of conduction is the distance between the V and the A is prolonged. And this increases the probability that the conduction is occurring via the normal conduction system. And this is very important to detect because you need to do what is the reason was the intention of ventricular pacing is to detect possible pathways of conduction. Another thing that's very important during ventricular pacing and will be important also during atrial pacing is that with pacing, tachycardia may be induced. And this is one of the purposes of pacing, to induce tachycardia. And by induction of tachycardia, you study it and determine its etiology and then determine the possible ablative target or the possible ablation target to terminate and cure this tachycardia. With increased pacing, sometimes I find that there is no conduction, and this no conduction occurs when I reach the refractory period of the AV node. So I find a ventricular beat with a based QRS complex without atrial conduction. And if I still go further with further encroachment on the refractory period of the ventricle, I find that the spike doesn't cause even a QRS complex because I reach the refractory period of the ventricle. So this was mostly the ventricular extra stimulus testing. Then I can do the ventricular straight pacing with gradually increasing the rate, and will give me similar informations like is there is conduction or not, where is the first A is conducting. We call this concentric atrial activation, and it will decrease with increasing rate. The VA time will prolong, and this is called decremental conduction, making me more sure that the conduction is occurring via the normal conduction system. Here I hear this is the straight pacing, and now takes more time when the rate is increasing
في التويليت والله
and
والله في
I
التويليت.
reach the refractory period of the AV node and the impulse is not conducted. This is an example. We call this Winkebach cycle length. After I finish ventricular pacing, I now go to atrial pacing. I use the same atrial extra stimulus testing and the atrial straight pacing. Atrial straight pacing should be kept to last because it is the most vulnerable to or the most capable of inducing atrial fibrillation. So I keep it to the end. What is the target of atrial pacing? First, I want to detect pathways of conduction. The normal pathway of conduction is the fast pathway inside the AV node. So I am trying to detect if there is any other pathway, like a slow pathway inside the AV node, or if there is even another pathway like accessory pathway. It's very important. The second important thing is that with atrial pacing, many forms of tachycardia will be induced. And this induction of tachycardia is very important. I can't ablate the tachycardia or cure the tachycardia if it's not inducible. I need to induce it to see where it come from and determine its ablation target. So here the most beneficial is atrial extra stimulus testing. I have a train. I call this train S1 with S2 at its end. Like here it's 500, 400. 500 is the distance between S1 and the S1. 400 is the distance between S1 and S2. This is 400 milliseconds. Then I measure the distance between the A and the H. What is the distance between A and the H? A is the atrium, is the impulse, the A signal at the caster at the His region here. And the H is the H signal that indicates that the impulse has passed through the AV node and reaches the His bond. This is the time of conduction inside the AV node. And this reflects the pathway of conduction. If this time suddenly prolongs, it indicates that the impulse conduction jump to another pathway. We call this AH jump, and this AH jump indicates the presence of an extra conduction pathway inside the AV node and the vulnerability to AVNRT. So I measure the AH, and I measure this in the extra stimulus, the SC2, A2H2, and I compare this A2H2 in this train with the A2H2 in the next train. The next train will be at 500, 390. And if this duration increased by 50 milliseconds or more, I can say this is AH jump, and this patient has dual AV nodal pathways and susceptibility to go to AV nodal entrant tachycardia. This is an example of prolongation. This prolongation can be gradual and occurs in the same fast pathway, but if it's suddenly increased, it indicates slow busway conduction. This is an example of prolongation. And sometimes I reach the refractory period, like if I did it to a normal person or a person without AVNRT or without supraventricular tachycardia, I may reach the refractory period without inducing anything. And even in patients with supraventricular tachycardia, sometimes the tachycardia is not easily inducible by pacing. In this situation, I can use straight pacing. Straight pacing will show the exact same pattern with possible H jump, possible induction of tachycardia, and possible reaching the refractory period. And sometimes the patient will need either isoprenaline or something like atropine to activate the AV node and make this pattern more apparent. So usually we don't take the patient inside the EB lab except after we have a documented supraventricular tachycardia. This is an example of reaching the refractory period of the atrium, and this is similar to what we saw from the ventricle, but here it's coming from the atrium to the ventricle. Now we'll go rapidly to some basic ECG review. Here, a rapid review of causes of supraventricular tachycardia. We have normal sinus rhythm with sinus tachycardia, and it will be apparent ECG with clear SNO with clear B wave. And atrial tachycardia, I have an abnormal focus inside the atrium
وانا اخر هنا في ظرف وقت المفروض يبقى 5 سنين بس عايز الشيء ده
causing the tachycardia, or I have the busway inside the AV node causing AV node reentrant tachycardia, or I have the busway outside
محمد
the
بس
AV node like
ذكر
in
إن موجود.
White syndrome causing AV reentrant tachycardia. This is an example. If we see, this is, I have here a B wave, QRS complex, normal B wave. Then I have a premature BEC, then a sinus. Then I have an atrial tachycardia. How I do this atrial tachycardia? I have abnormal B wave. It's the initiating cause of the tachycardia. So from this ECG, mostly this is tachycardia. And this is a very important concept to know when you take a patient to your EB lab to do a study. You need to review all his ECGs to make a plan. Is this patient have SCVT or not SCVT? What is the most possible diagnosis of his SCVT? To be ready with a plan and to prepare your protocol of management. So this is mostly atrial tachycardia. Here we have a termination of atrial tachycardia. Please, are the ECGs now visible or not?
not visible يا دكتور محمد.
Okay, I will reshare.
كده ظهرت تمام.
Now, okay. So
Okay.
we review again. This is the cause of supraventricular tachycardia, sinus tachycardia, atrial tachycardia, AVNRT, AVRT, and this is the example of initiation of atrial tachycardia. I have here a sinus rhythm followed by a premature atrial beat, a sinus beat, then another sinus beat, then atrial tachycardia. For our
عايز اتفرج معاك يا لينا.
for our colleague not very experienced in ECG, we know sinus rhythm first by detecting the QRS complex. The QRS complex is usually the easiest thing to detect in the ECG. This is this long waves, and I use lead 2 and see before each QRS complex. I usually see this clear B wave. This is the sinus B wave. Here I find no visible B wave clear. So this is atrial tachycardia. And in this example, it's very apparent that I have a B wave that's inverted. In lead 2, the normal sinus beat should be upright. Here, it's inverted. Suddenly, the tachycardia ends, and now I have a normal sinus B wave, and the patient regained sinus rhythm again. This is maybe the most typical pattern of supraventricular tachycardia ECG that's visible either on ECGs for patients done during tachycardia, either during on the monitor screen or during Holter monitoring of these patients. This is the classic pattern of supraventricular tachycardia, and this is the most usual ECG we'll see before admitting the patient to the AB lab. And in many cases, if I don't see except QRS complex, it may be AVNRT, because with increasing experience, we will look for retrograde B wave and something like this to detect or to make the diagnosis more accurate from the ECG, but this is enough to get the patient to the AB lab. This is another example. Here on the right, I have the normal sinus rhythm. Clearly here I see the positive B wave in lead 2 preceding the QRS complex, and during the tachycardia there is no such B wave, and I see this retrograde B wave. I have some other types of arrhythmia we didn't discuss today in the arrhythmia, but they are very common. The most important of them, atrial flutter, atrial fibrillation, and despite being by definition supraventricular tachycardias, because they are almost separate entities, we use atrial fibrillation if you are describing atrial fibrillation, and atrial flutter if you are describing atrial flutter, because they differ in management from normal supraventricular tachycardias. I diagnose the flutter by presence of flutter waves, either positive or negative, sometimes without even baseline between beats. This is a very clear example of flutter waves. With flutter waves, sometimes the heart rate is regular and sometimes the heart rate is irregular. Atrial fibrillation shows complete irregular rhythm, completely irregular rhythm, and the baseline is also completely irregular. You may find these find undulation or even no undulations at all, and this is a very nice, though artificial example of atrial fibrillation returning to sinus rhythm by DC shock. Here I see the irregular QRS complex and the irregular baseline, and after the shock, I see the clear baseline except for the B wave, the QRS complex, and there is no electrical activity between beats. Here I see the continuous atrial electrical activity between beats that's characteristic of atrial fibrillation. Now, this is the standard pattern of ventricular tachycardia, and despite we didn't talk about ventricular tachycardia today about in the EB lab, this is very important clinical entity, either to occur in the patients in the CCU or even during your studies. Sometimes the patient go in VTAC. Of course, many of you who used to work in coronary labs, this is very familiar to you. And this is monomorphic ventricular tachycardia. This tachycardia may be pulseless and need immediate resuscitation. And any wide QRS tachycardia that's recorded is mostly ventricular tachycardia. And in my knowledge and my practice, I almost diagnose wide QRS tachycardia as ventricular tachycardia. This is a different type. Wide QRS tachycardia means ventricular tachycardia. And here we come to ventricular fibrillation. Ventricular fibrillation is a very, very important entity to know, because the life of the patient depends on early recognition of this rhythm. With this rhythm, the patient needs immediate defibrillation and cardiopulmonary resuscitation and CPR. So detection of this rhythm is very important, because this is a rest rhythm. The patient has no electrical activity and no circulation now. So the patient need to be defibrillated as soon as possible, either by external either by automated defibrillator or by using our conventional DC units in cath labs or in our CCUs. Here we see a pattern of almost regularized ventricular tachycardia followed by degeneration into fibrillation. First, we see this is called coarse fibrillation. This is called fine fibrillation according to the amplitude of the waves. But fibrillation, by definition, means no organized electrical activity is present. So the patient is pulses. Here, the patient is arrested, no circulation at all. If you didn't defibrillate the patient soon, you will lose the patient. Here, this is another form of arrest rhythm, the asystole. Asystole, and if you see this, you need to start cardiopulmonary resuscitation CPR, but you should check connections, because if the connections are wrong, you will have this without the patient being arrested. So we just took a hint to supraventricular tachycardia, ventricular tachycardia, and ventricular fibrillation. Very rapidly to end our discussion, we will cover very fast the heart block. The heart block is with ECG. I have B wave causing the QRS complex. The relation between the B and the QRS complex is the BR interval. And if this BR interval exceeds 5 small squares or 1 big square, this is called prolonged BR interval, and this defines the first degree heart block. If some B waves are not conducted and cause QRS complex, we are in the second degree heart block. If this change in BR interval is repeated and its gradual prolongation followed by one beat of non-conducted B, then a BR which is short, then I call this type Winkbach or Mobitz type 1 second degree heart block. If this conduction is not doesn't show regularity and I have occasional non-conducted B waves, it's called Mobitz 2 second degree AV block, and we start serious problem from this type. And if I have high grade block with one of 3 or 1 of 4 beats are conducted, this second degree heart block, but advanced second degree. And if I have no conduction at all with completely irregular BR intervals and regular B waves, regular RR interval, but irregular BR intervals, this is complete heart block, and usually this needs basing either temporary if there is a reversible cause or permanent if there is a reversible cause. Thank you for your listening, and any question in the last few minutes available, I'm ready.
سؤال لو سمحت لك.
اتفضل.
يعطيك العافية. السيجنال بتبين بالسلو باثوي بلوك بتكون في اتريال سيجنال من الرايت اتريوم ورايت اتريوم also من الهيس سيجنال والسي اس also سيجنال اتريوم بس بيكون not going to ventricle signal. يس هيك؟
لا ما بقاش فيه تو ventricular signals. لا هو حضرتك بتتكلم على السلو باسواي، مظبوط؟
نعم.
السلو باسواي اللي هيحصل ايه؟ ان حضرتك هتلاقي الاي هي ايه واحده اللي حضرتك عاملها بتاعه البيسنج، الاي 2، تمام؟ وبعدين هنلاقي اتش اللي هو اقرب شكل ليها، يمكن هو في السلايدز ده هو الشكل ده، ان انا هلاقي المسافه بين الاي والاتش بقت كبيره قوي، انما هي 1 ventricular beat. اللي حضرتك بتقول عليه السكند بيت دي ممكن يكون قصدك على الايكو بيت، انما احنا عندنا في السلو باسواي ان انا هلاقي فجاه ان الاي اتش انترفال زاد قوي 50 ملي سكند اور مور، انما هي 1 في بس.
اوكي، وبس نحكي انه سلو باثوي بلوك ايش بتصير السيجنال؟
سلو باسواي بلوك اولا يبقى حضرتك هتشوف اي ويف من غير اي كوندكشن، مش هتلاقي كوندكشن لان هو قفل فما حصلش فيه كوندكشن. فلو كان حصل سلو باسواي كوندكشن بلوك وما حصلش توصيل يبقى هتشوف ايه بس. لو هو كان الفاست باسواي بيوصل يبقى هتشوف ايه اتش صغيره وبعدين في. فاللي حضرتك تقول سلو باسواي بلوك لو انا ببيس من الاتريوم يبقى انا ممكن اشوف ايه سيجنال بس. الجامب انا مش بشوفها كتير لما ببيس من الفنتريكل للاتريوم، وان كان ممكن تتشاف، انما هو لو حصل بلوك يبقى مش الامبلس مش هتتوصل. هشوف انا الامبلس الايه اللي انا عاملها بالبيسنج من غير فنتريكولار سيجنال او العكس، انما مش هشوف حاجه لو هو في بلوك.